Hello, everyone. Are you ready to start? I'll let everyone grab their lunch real quick if you'd like, if you have not. Okay, we're going to start here in just a couple of minutes. Now we're finishing grabbing our lunches. But good afternoon. What a beautiful day it is outside. I am glad that all of you joined us instead of taking the day off to be outside. So thank you. Well, welcome to the October Spark Luncheon. My name is Anita Collins, and I'm the chairwoman of the Garland Chamber Board of Directors, and it's an honor to serve. I'd now like to recognize all the leadership in the room and those that have joined us via Zoom. So please hold your applause until everyone has been introduced. From our Garland City Council, we have Mayor Scott LeMay. District 4, BJ Williams. From the Garland City Senior Staff, we have the City Manager, Brian Bradford. Brian always might as well stand up and stay standing. He gets called several times. We have the Assistant City Manager, Judd Rex. And from Dallas College, Richland Campus President, Dr. Kate Eggleston. From the state of Texas, elected officials, we have the Texas State Senator, District 2, Bob Hall, staff member John Vick. And then from our Garland Chamber of Commerce Board of Directors, we have Brian Bradford, City of Garland, Donna Butterfield, Frost Bank, Dr. Kay Eggleston, Dallas College, Richland Campus, same thing with Kay, and Chris Merlick, Label Solutions, Inc. Okay, let's give them all a round of applause. I hope I didn't miss anyone. Thank you. All right, at this time, I'd like to recognize our sponsor, Donis Cole, president of Baylor Scott and White Medical Center of Lake Point. Donis can come on up, but I have a few quick things to say about him. I had the honor of serving with Donis on the Baylor Scott and White Garland board. I do not believe there's anyone that is more passionate about the healthcare needs of our community. He not only cares about our family and friends as patients at Lake Point, but he cares for the well-being of every doctor, nurse, staff member, and all the families and caregivers that Baylor and Scott White serves. And Donis also has this very special gift of remembering everything. He remembers the details and everything. Some things we don't want him to remember, but when you're dealing with the loved ones, the people, that leaves those details, and caring about their names leaves that lasting impression of care. So his servant leadership is obvious with every moment you spend with him, and you realize that he's passionate about making a difference in not only the healthcare industry, but in each of our lives. So please welcome our friend and leader, Donis Cole.
Thank you, Anita. Such kind words, and certainly something for me to live up to. So Certainly want to thank the Chamber for providing us the opportunity to sponsor this event today. At each one of your seats, there is some information about Baylor Scott and White Medical Center Lake Point. And there is also a small panel card that is a better way to screen for lung cancer, which is advertising our low-dose CT. So if you have time, if you will look at those documents. Anyone that is joining the event virtually, those items have been emailed to you, and Lisa will be sending those out after the event again. So there's a short video about the hospital, and then I will announce our speaker.
My family has been in Texas for more than 5 generations, and I came to Lake Point because I saw so much potential in this community and the growing area around Rowlett. We are now part of the Baylor Scott and White Health family. What is exciting about this particular time is how we have expanded the hospital to meet the needs of this community. We are blessed to have the new tower in Rowlett. The tower has brought a renovated dining hall, as well as a large lobby area that is comfortable for our patients and family members. We've expanded post-surgical beds to accommodate the volume of patients that we take care of. So patients are not having to be transferred from the facility. We are able to accommodate those patients at this location.
I am a mother of 5 with 2 grown daughters of my own, which is why it is so important to me and my family to be involved with a hospital who prioritizes women's services. In addition to offering full services for high-risk pregnancies, we received our Level 3 designation for our neonatal intensive care unit.
We're here for emergent needs, but also urgent and minor needs as well. To meet that need, we've opened up a vertical flow area that lets patients come in and get seen for those urgent and minor care needs and be moved through the department, but also help reduce their wait time as well. I want to be able to bring my family member here, just like I want the community to be able to bring their family here. That's the goal, that's our drive, to make this where when you walk in, you feel like your family.
When I work to build services and new services, I have my family in mind. I have your family in mind, so that we do not have to leave our community to receive the care that we need. This is my home, this is your home, this is our community, and this is our hospital.
Your healthcare needs. It is my honor to introduce Dr. Amanda Abbott. She is a palliative care physician who is also board certified in internal medicine. She was born and raised in the Metroplex, earning her bachelor's degree in biology from the University of North Texas in Denton, and then her doctorate degree from the UNT Health Sciences Center in Fort Worth. She then completed internal medicine residency in Central Arkansas, followed by a fellowship training in hospice and palliative care at the Texas Tech Health Science Center in Lubbock. She has presented at several national and regional conferences in the last few years, and has recently joined the Baylor Scott and White family as the medical director for supportive and palliative care at Baylor Scott and White Medical Center, Lake Point in Rowlett. So please join me in welcoming Dr. Abbott.
Thank you, Donuts. So I am thrilled to be here to talk with y'all today about palliative care because obviously it's what I chose to specialize in, so it's something that's very important to me and I think very important to our community as well. Some of you may have never heard of palliative care. Sorry, I'm trying to remember what you told me. Okay, got it. Some of you may have never heard of palliative care before, and there's a reason for that because it is one of the smallest medical specialties and also one of the relatively newest. It was only recognized as a board recognized specialty in 2008. So it may not be the newest or the smallest, but it's definitely up in there. So what is palliative care? Well, to start with, the word palliative comes from the Latin root palliare, which means to cloak or to cover. And so the verb palliate is to make a disease or its symptoms less unpleasant or severe without necessarily removing the cause. So if it was 20 degrees in here, this is my example, which it probably was last February, and I were to offer you a coat, then I wouldn't have changed the fact that it was 20 degrees in here, but hopefully I would have made you a little bit more comfortable. In essence, palliative care is the original intent of medicine, because before we had antibiotics and surgeries and chemotherapies, most of medicine was concerned with helping patients who were feel better, even though at that time, most of the time their illness wasn't curable and often it was fatal. So the definition of palliative care, the updated definition, so to speak, of palliative care, as written by the Centers for the Advancement of Palliative Care, is that palliative care is a medical subspecialty which is primarily concerned with patients who are suffering from serious illness. And the goal of the specialty is to provide relief from symptoms and stress that are associated with the illness in order to improve the quality of life for not only patients, but also for their families. So I know I just said that palliative care was the original intent of medicine. So if that's the case, then why do we need a specialty called palliative care? Well, as we came up with all these new cures, these antibiotics and chemotherapies and things, the attitude of medicine toward death started to shift over time to the point where people started viewing it as a failure of medicine. And my next quote is a little bit, maybe not the most sensitive quote, but it is, I think, originated from the Onion, so bear with me. World Health Organization officials expressed disappointment Monday at the group's finding that despite the enormous effort of doctors, rescue workers, and other medical professionals worldwide, the global death rate remains constant at 100%. So, it's not necessarily a pleasant thought, but it's true. Someday we will all die, and no amount of medical advancement or technology is going to be able to change that fact. Now, our medical advancement, it helps us to live longer and better, but it's not going to change the fact that in the end, that's a constant in life, 100%. So and by the way, serious illness, I skipped over that part. Serious illness is defined generally as a disease which would be likely expected to result in a person's death eventually. So it's a life-limiting or what we call life-limiting or life-threatening illness. So you may be thinking, well, if palliative care deals with people who have terminal illnesses, then is it the same as hospice? And the answer to that is yes and no. So all hospice is palliative care because hospice is a Medicare benefit that's designed for people who have terminal illnesses and are within what is expected to be their last 6 months of life and have chosen to forego curative and life-sustaining therapies. So it's a very specific subset of patients who are suffering from serious or terminal illness. Palliative care, however, and the goal is 100% palliative care. All hospice is palliative care. But supportive palliative care is not necessarily hospice because people can receive supportive palliative care while they're undergoing curative and life-sustaining treatments. It doesn't have to be one or the other. On a population level, it looks kind of like this. Palliative care is administered over the span of years, ideally starting with the diagnosis of a serious or life-threatening illness. We treat the of the population, which accounts for about 60 to 70% of all healthcare costs, and approximately 80% of all suffering that's associated with medical conditions. Hospice ideally would happen over the span of 6 months, although the time frame is variable. It can be longer, it can be shorter. There's no requirement that you have to die within 6 months on hospice. They treat about 1% of the population that dies annually, which is about 5% of Medicare. I know that I just said that hospice and palliative care are different things, but in order to talk about the history of palliative care, we have to talk about the history of hospice as well, because it, in a way, kind of originated first. So the history of hospice, of course, the first hospitals that were built in the world were concerned, were nicknamed houses of death, because oftentimes back then, if you were sick enough to go into the hospital, you might not make it out. This obviously started to change over time to where we started focusing more on cures and on extending life. And there wasn't really a dedicated place for us to provide comfort care until the mid-1800s, when a young woman named Jeannie Garnier, who was a widow and a bereaved mother, got together a group of friends that were in a similar situation, and she founded the, and this is a typo, I apologize, she founded the I practiced this, Doms de Calvaire, not Calvaire, whatever that says, and which she called a home for the dying. And it was concerned mostly with respecting people, respecting their wishes, and helping to make their last moments more comfortable. Unfortunately, due to death being viewed as a failure of medicine at the time, she didn't really get a lot of input or support from the physicians and the medical community. However, in spite of this, she did inspire a movement, and several different institutions started to pop up similar to hers across Europe. But the hospice movement didn't see real increase in momentum until almost just a little over a century later, with a lady named Cicely Saunders. So Cicely Saunders was trained as a nurse during the early part of World War II, and then as a social worker. And during her time as a medical social worker, she met a young man named David Tesma, who was dying of terminal cancer. And his death, his death really had a profound impact on her, and it got her to thinking and becoming more and more frustrated with what she viewed as doctors' ambivalence toward the dying patient. It really started to bother her, and she wanted to do something about it. So she talked to her orthopedic surgeon, who said, very frankly, as a nurse, I wouldn't listen to you. So you need to go to medical school. And so she did. And in 1967, Dr. Cicely Saunders founded a place called St. Christopher's House, which became the first and the benchmark institution and the model after which all hospices have really been built since. This place was pretty remarkable, especially for the time. It brought together terminal patients and a staff that was committed to learning the best ways to care for these patients to make their last days more comfortable. So they pioneered the use of oral opiates for pain control. They did lots of clinical research, and they really invented this idea of what we call total pain, which is still one of the concepts that we focus on in palliative medicine, which basically says that a person who is terminally ill may be suffering from physical pain, but a lot of their pain may also be due to emotional, spiritual, psychological suffering. And unless we are able to address those roots of the problem, we can't give them enough pain medications to control what appears to be pain. In 1974, this is kind of where America's story starts. By the way, Dr. Saunders was awarded Dame Commander of the British Empire in 1979, and henceforth was known as Dame Cicely Saunders. So I have to give her the correct title. America's story with palliative care really began with this lady, Florence Wald. She was the dean of the Yale School of Nursing at the time, and she heard Dr. Saunders speak in 1963, and it left what she called an indelible impression upon her, because up until that point, she thought that the only people who were concerned with dying patients were nurses. She didn't think that the doctors cared. It left such an impression on her that she actually contacted Dr. Saunders and spent a month at St. Christopher's House, learning everything that she could from her, and came back to found America's first hospice, which is still in operation, the Connecticut Hospice, in 1974. Around that same time, in 1975, Dr. Balfour Mont, a urological cancer surgeon at the Royal Vic in Montreal, also heard of Dr. Saunders' work. And interestingly, when he contacted her to ask if he could come and shadow her and learn from her, she said she would not hear of it, because she thought that he just wanted to have a short European vacation with his wife, and that he would then go, come for a couple of days, see a few plays and go home. And so she said, you want to come here and learn from me, leave your wife at home, stay a week, roll up your sleeves and be prepared to work hard. So he did, and they did end up having a lifelong friendship from that point on. He came back to the Royal Vic, where he had seen what he called an abysmal inadequacy of pain control in situations that weren't normally difficult because the patients were terminal. He came back and founded the first hospital-based palliative program in North America. So he's known as the father of palliative medicine. This formation, close together formation of the first hospice and the first palliative care program caught the idea of a lot of politicians. And so in 1982, the Medicare hospice benefit was approved and it was made permanent in 1986. And then in 2008, palliative care was officially recognized as a board-certified medical specialty. And that's really the history of palliative care. Obviously, it's evolving and growing because over the last several decades, we've had a lot of changes and a lot of increases. Sorry. So to put this more graphically, we would divide the history of palliative care into 3 eras. So the first era is where there's no palliative care or no formal palliative care, no hospice. So a person is born and eventually they die. And at first, they're receiving preventative therapies to keep them healthy. And then at some point in time, they're about to develop an illness or more than one illness and start receiving curative or life-sustaining therapies. And this may be something as simple as blood pressure medications or chemotherapy, depending on the situation. During that time, most people who develop chronic illnesses have a series of acute or acute on chronic events that will affect their health and become more frequent up until the point where they pass. The second era of palliative medicine is where we added the idea of hospice. And so when focusing on comfort measures in the last 6 months of life, we are able to do away with a couple of those acute events, hopefully, or at least to make them less severe. And we add on the benefit of bereavement. And this is a big component of hospice because it offers support to a family after a patient has passed. But still during this time, there was no palliative care. So there's really kind of this abrupt shift from curative or life-sustaining therapy to comfort-only therapy, one or the other. The third era in palliative medicine is the addition of palliative care. This is on kind of a gradual slope because ideally somebody would be consulted for palliative care at the development of a serious terminal illness. And then over time, as their symptoms become more severe, the amount of palliative care that they're requiring would increase, and eventually they would maybe elect to focus on comfort care only, and at that point they would elect hospice if they had a life expectancy 6 months or less. This is another graph kind of showing the same thing. I actually don't like this one that much. I kind of wish I had taken it out, but it does kind of demonstrate how we have a low level of palliative care that is able to stick with people while they're in tandem receiving curative and life-sustaining therapies. And then as they get sicker, we need to increase that palliative care, even if they're still receiving those therapies. The history of palliative care at Baylor, it is also kind of broken into 3 eras. And we're going to call them 1.0, 2.0, and 3.0. Okay, so palliative care 1.0, it was early in the 2000s. We had a palliative care consultation service. It was inpatient only and was really exclusively for the acutely dying patients in the hospital. There was no outpatient option. We didn't see a whole lot of chronic conditions. We had part-time staff and suffered some personnel loss. However, even despite all those hardships, we did receive the American Hospital Association Circle of Life Honorable Mention in 2007. Palliative Care 2.0, we rebranded. So we could now call ourselves supportive palliative care because we wanted to get across the point that now we were going to be able to and have the resources to be able to focus on more chronic conditions in which the patient would need support specifically. And so we became supportive in palliative care, started seeing more things like heart failure, cancer, and we were able to have a limited outpatient service provided and developed a full-time professional staff model, which is a lot more, of course, stable. So I'm trying to stay in the camera. I apologize. And during that time, we were one of the first 10 programs in the country to become Joint Commission certified on hospice and palliative care, and the first one in Texas, by the way. And we received the American Hospital Association Circle of Life Top Award for Best System Program. But we didn't stop there. So palliative care 3.0 has been a rapid increase in the last 10 years, 6 years really, into where we have palliative care programs at many, many hospitals. I'm not actually sure how accurate this number is. I think it's actually more than that now, with Lake Point, of course, being the most recent addition to inpatient palliative care. And we have outpatient programs at 5 different hospitals, 6 different hospitals, I'm sorry. And we started to develop kind of a training program for other practitioners so that maybe they can help interfere early on and offer some basic palliative care, even if they're not consulting us yet. We've been recognized as a national leader in palliative care and even been invited to share our experiences at the National Academy of Science. So who are our patients? As I already mentioned, most of our patients have chronic, life-limiting, life-threatening illnesses. And some of the more common ones include heart failure, COPD, heart disease, kidney failure, liver failure, diabetes, dementia. These are all kind of the basis of palliative care. But that's not our only patients, especially in the hospital. We see a lot of more acute patients. So patients who come in after trauma, after cardiac arrest, people who are in the ICU and have complicated courses. And unfortunately, for the last year and a half, a pretty decent amount of our consults have come from COVID patients who are severe. Lastly, our patients are the families. And this is a really important point of palliative care. I honestly think, in my opinion, one of the more important points, because even though we're focused on providing symptom management and comfort to the patient themselves, the families are suffering too. And that's something that we really, really need to pay attention to in medicine, and something that often gets overlooked, especially during COVID, when the family is not sitting right there at the bedside. And so a lot of times, nowadays we're calling families, we're checking on how they're doing, we're getting them involved, we're helping them resolve conflicts when they don't agree on what the patient would want or things like that. That's a big part of what we do, and being there to comfort the patients. I've many times been hugged by families after the patient passed because of how much we did to try and help their family get through this difficult time. So now I would like some audience participation if y'all are willing. There was a study done about what things, it was in terminal patients, what things are most important to people as they get near the end of life. If y'all don't want to chime in, you don't have to, but everybody has anything.
Family.
Sorry, family? Okay, good, good.
To have as much agency
As much agency? Yes, so, yeah, awareness and
resources,
resources, yes, having resources available to them.
and understanding of what's happening to them.
Yes, knowledge of what's happening to them. And kind of being informed and kept in the loop, right? So this study actually found that these were the most important things to people. Freedom from pain, which is something that, us as physicians are expected. But a lot of these are less tangible, peace with God and mental awareness, which is something that we often overlook, like you said, to feel like their life is meaningful, to have their affairs in order, things like that. Interestingly, this chart is things that patients listed as important and doctors did not. So that's kind of the discrepancy there. A lot of similar themes as the other list, that was the top list. So what can we do to help with those things? Because obviously we can't give a pill to make somebody have peace with God. That's not going to work. One of the things that we do is pain and symptom control, which is a lot of the time that's kind of the medical staff's area of expertise, is the pain and symptom control, making sure that the patient's not physically suffering. But that peace with God point was number 2 on the list. And so we work really, really closely with our spiritual care department, our pastoral care, just to address any kind of spiritual needs that the patient has, whether they want to pray, whether they want to make peace with family, things like that. Our chaplains at Baylor actually help us fill out medical power of attorney and advanced directives and things like that as well to help with advanced care planning. Turn it off. Oh, okay. Okay, so sometimes we need the help of Child Life. Usually this involves a patient who has young children or young grandchildren. And Child Life is really excellent at explaining to these children what's going on a level that they understand, helping them to cope, helping them to form memories that they can carry with them. Sorry, I skipped. Nutrition and speech therapy often becomes important at the end of life as people have difficulty swallowing and eating, and we're able to offer counseling and assistance in helping with those things. And music therapy, I was actually in a room just the other day in an ICU room, and this lady wheeled in her harp and started playing for the patient, even though he was intubated, because, you know, you may be able to hear it and making some peace for that. Social work is one of the big points of palliative care. They are able to help us, especially with things like placement. So if the patient is not able to get home, then maybe we can get them home with some help. Maybe we can get them to a nursing home. Maybe they need to go to a long-term facility. Maybe they want to go home with hospice. Social work can help us with all of these things and many more. Pop into their office every day, multiple times. So, bereavement counselors for after a patient passes. And a big piece is advanced care planning. And several of these different services will help with that. But it's kind of a big part of what we do, because we want to know what your patient's treatment preferences are before we get to the point where they can't tell us anymore. So palliative care is a multidisciplinary approach. It is a, you know, it's a group, it's a team effort, and that's become something that's really a theme throughout palliative care. This is something that I have often said to patients, pretty much every time I'm consulted. My job is to find out what your wishes are, what's important to you, and to make sure that everyone else knows what they are and tries to respect them. And that really is my job, not to talk them one way or another or anything, just to find out what their values are. So the mission of supportive palliative care at Baylor is to improve the quality of life for patients and families facing serious, often life-limiting illness, to collaborate with all the members of the healthcare team, to provide relief of total suffering, be it physical, psychosocial, or spiritual. And I know y'all are all business people and research-minded, and so there are some statistically, scientifically proven benefits that palliative care offers. We've been able to do studies over the last couple of decades that prove these, and you'll see the little reference numbers out there if you want to know what the studies are. They're there. So palliative care provides less pain. I'm going to get my list here just so I don't miss anything big. Palliative care statistically provides less pain, better symptom control, and better quality of life. Better support for the families, which leads to less depression and PTSD and better bereavement for families. Better communication between the medical team and the patient, which leads to an agreement of importance of the treatments with what the patient values. Better advanced care planning, which is kind of along the same lines. This is a big one. Better survival in metastatic cancer patients who are referred early. So this doesn't mean better feeling survival. This doesn't mean better quality of life. Those things are already proven as well. This means that people who got palliative care early on in their diagnosis of metastatic cancer lived longer than those who didn't, by on average several months. And a lot of this can be attributed to better support, patients not feeling like a burden, and a big one is not receiving chemotherapy when their body is too frail to take it. In fact, the cancer benefits are so high that the American Society of Clinical Oncologists recommends early supportive palliative care for all metastatic cancer patients. And there's also lower costs for patients and families. And this may not seem like the biggest thing when we're talking about life and death and healthcare, but this is a huge source of stress for patients and families, because in the last year of life, a lot of patients will end up spending exorbitant amounts of money wanted to begin with. And it causes them a lot of distress. It causes their family a lot of distress. It can leave their family in financial difficulty. So this is really important to people. All in all, palliative care is scientifically proven to be better care. There's also proven benefits for healthcare organizations, and some of these are along the same lines. There's better physician satisfaction, better patient satisfaction, less medical futility and non-beneficial ICU treatments, fewer preventable readmissions, lower cost during an admission, even if the patient doesn't end up elected to go on hospice or to go comfort care. They end up saving on average $3,200, and a lot of that does transfer to the patient themselves. And lower future costs. So these patients aren't being readmitted in the next 30 days because they're being better prepared in the hospital for what's coming. And going home a lot of times with more support, and that's a big thing. So if they're going home and we were able to get them home health, then maybe we can prevent them coming back in the next 30 days. Maybe we can prevent them from going to the ICU, things like that. So all in all, palliative care is scientifically proven to offer better quality metrics and a lower price. It's all in order. So the goal of palliative care is to live as well as possible for as long as possible, adding days to life, adding life to days even when days can no longer be added to life. There's a lot of these little phrases that have a lot of meaning behind them, but I wanted to include some. And so I wanted to talk about one of the foremost supporters of palliative care currently. This is Dr. Atul Gawande. He is a endocrine surgeon at Harvard, at Brigham and Women's, and a professor of surgeon at Harvard. And I have his quote here, and I want to read it for you. And it's fairly long. I did paraphrase it to some extent, but I don't have it memorized. Let me see if I can use a paper right there. I don't have this quote memorized. And I tried to memorize it, y'all. I really did, but it's quite long, and I knew I would mess it up if I tried. If I did too much. Yes, thank you so much. Sorry, I apologize for that. So he said, and the reason that I wanted to include this quote, even as long as it is I really could not say what palliative care does better than he said it. And so I will credit him with it and read it for you. We are lucky to live in a time when the vast majority of us will live long enough to grow old. But although medical capabilities allow people to live both longer and better lives, nearly all of us will also face serious illness and impairment along the way. As people become weaker and sicker, they and their families ask doctors a seemingly simple question. Isn't there anything you can do? The thing is, there's always something we can do. We can operate, provide chemotherapy, put in tubes, insert devices, attach machines, carrying on this way right to the very end. And I saw over and over again how much suffering we caused and how much we even shorten people's lives out of a desire to keep doing something, anything, no matter what. But it can be difficult for clinicians, patients, and families not to regard any other choice as essentially doing nothing. I wanted to understand how to do better, but I didn't know how. People have priorities in their lives besides just living longer. The most effective and important way to learn these priorities is to ask people. When we don't ask, the result is suffering. For care and treatment often ends up out of alignment with what matters most to individuals. But when we do ask, and we align our care with their priorities, the results are remarkable. Are there any questions? And I'm going to put this up here while we do questions. These are just a couple of books. This one is written by Atul Gawande. And this one also was the one published in 1969 that actually inspired Dr. Lamont to become interested in the dying process and spawned kind of the birth of palliative care. So I will be honest with you, I have not read these books all the way through, but I've heard that this one in particular is absolutely excellent. Are there any questions? Yes.
So Dr. Abbott, I've always been familiar with palliative care, but it's truly experienced the benefits. When my father was sick and getting towards the end, I cannot tell how wonderful that program is. It gives families hope, it gives them resources, it helps the other doctors that are part of the medical team. It's just, it's phenomenal. So thank you for that presentation. But my question is, why do you think it's taking so long to have palliative care as a specialty?
So I think that question actually is best answered by Elizabeth Kubler-Ross herself, because she said that she said this before Congress, and I debated including this quote. I do have this one. We live in a particularly death-denying society, and we isolate people who are dying and people who are old because it serves as a reminder of our own mortality. So quite simply, people just don't want to think about death. And so on a daily basis, we don't want to think about how that's inevitable eventually, and we feel like for some reason that if we think about it, if we talk about it, it'll happen faster. And I think it's just something that people don't want to think about, and something that people want to fight against, and so they forget to, I guess, accept that it is a reality. Yes, sir?
What's the story behind you choosing this specialization?
Okay, so I actually thought I might get asked that, and I put on here.
It's a great specialization, but it's a rather morbid topic.
It is. So, and I will say my answer to that is not to me. I don't feel like it is, because my job is not to help people die. It's to help them have comfort as that happens, because it's never going to happen. I've been asked this question a lot, and my answers are always kind of cliche. It's what I was born to do. I just feel fulfilled, things like that. But that doesn't really mean anything. And then I read this quote actually a couple weeks ago that was Balfour Mott explaining why he went into it. And so I'm actually going to read it, but I will insert my own specialty rather than his. So it was clear to me that as much as I enjoyed internal medicine, this was far richer. This was what I had to do. It was totally unethical to leave healthcare the way it was. I did it because it mattered. It was meaning charged. There really is a lot of suffering out there. It really is unnecessary, and we really can do something about it. So, I like getting rid of patients. That's the one I use when I'm just trying to, Yes?
So if you have a friend or a family member that you feel like is kind of at the beginning of this journey and they would benefit from palliative care, like logistically, how do they bring that part onto their medical team?
Okay, so palliative care is a consulting service, and so at least at Baylor, not everywhere, but if they're in the hospital or if they're seeing a primary care physician, then they would want to bring that up to the primary care physician or to their attending physician and just say, I'm interested in talking to palliative care, and some physicians have this idea that palliative care and hospice, they still think they're exactly the same. And so they'll say, no, you're not ready for that. And that's kind of where we rely on not only other clinicians, but on patients and families and all of y'all sitting in this room to help us educate on that. And so to say, well, I really think I am actually, appropriate for palliative care because I have a serious illness and I want to try and, get as much support as I can early on. And maybe to assure the physician that if they're not ready for hospice, just say, I'm not talking about hospice, I'm talking about palliative care. If they are talking about hospice, of course, then, have that discussion. But that's a great question.
For those of us who are not healthcare professionals, how do we advocate for palliative care?
Okay, so and that's something that I was kind of wondering what was the purpose of the kind of takeaway from this presentation. One of the big things is education, is kind of spreading the word that palliative care has been misunderstood for too long, which is why we rebranded it to supportive palliative care, because we really want to emphasize that support piece. The other thing is, on a personal level, talk to your families about what your preferences are. Talk to them about what their preferences are, because the most stressful times that we see in the hospital and in the hospice and things like that is when we have patients who haven't talked to their families and now they can't. And it's something that's important for all of us. Fill out an advance directive. There's actually a tool Wanda was pushing in Congress for advanced directives to be offered and encouraged in any adult 18 years and older. Because it just tells us as medical professionals what your choice would be if something happens. It's not saying that it's going to, it's just saying if. So fill out an advanced directive, elect a medical power of attorney. That way your family is not left wondering who should make this decision. And especially talking to other family members, especially, elder family members and things like that about, what would you want if this happened? Not saying that it's going to, but what would you want if it happened? Because we don't want to be left in a place where we're at that point and we don't know.
So the holidays are coming up and we're going to be around family by and large. What is one easy intro question to start this conversation with older relatives?
That's a good question. And I think it's somewhat on an individual basis, because there's some people that put up walls immediately. And I assume you're probably talking about people that sort of be like that. Because, you can approach the topic as kind of like, hey, you even mentioned, hey, I was at this thing the other day and I was just thinking, what would you want me to do if we were to be left in a situation where you couldn't make decisions for yourself, even temporarily, and have you considered filling out an advance directive, and if they display, aversion to that, one thing that you can always tell them is, I'm not saying this is going to happen. I really want to know what to do if this happens, because I don't want to be having to make that decision myself. I want to know what you would do in that situation, if it ever happens, now or 10 years down the road. I don't know if that's necessarily a great way to approach it, but I think just kind of letting them know that you're not trying to say, I think you're old and we need to have this discussion, but just saying, hey, I pulled out my advance directive the other day and I was just wondering what would happen if this were to happen to you. What would you want me to do? A lot of times family members, by the way, will say, oh, you know what I want. That's a pretty common response that we get. Well, my daughter will make the decision. She knows what I want. Well, have you talked about it? No, she knows. Okay, well, maybe you should talk about it because maybe she doesn't. Yeah. So.
I thought I'm pretty familiar with healthcare various specialists because I'm a clinician consultant, but this is my first time for this specialties. So my question is, where do you find this palliative specialty doctor? Is that you go to different medical insurance website, they have this name and you can find it? What is also curious about, what's the difference between this specialty doctor with the hospitalist, internalist that work in the ICU department and in primary care? So what's the day-to-day duties difference among those different specialties?
Right, okay, so the first question on how to find one, it's really just like any other subspecialty. So if you need a cardiologist, you tell your primary care doctor, I think I need to refer to a cardiologist. It's the same thing, and the primary care doctor will be able to get you in touch with a palliative care doctor. If you're in the hospital, specifically Baylor, not to brag too much, but if you're in the hospital, you can always ask the attending physician. That's actually the way that most people end up getting referred to palliative care, because on a normal routine visit, it doesn't often get thought of. But if it's brought up by the patient, then a primary care physician in the office can easily make that referral, just like they would make any other referral. As far as different, responsibilities, so we focus on providing relief of care and things, relief of symptoms and things like that. And one thing that we spend a lot of time talking about with patients is, instead of going in the room and asking them, how was the night? How did you sleep? Are you nauseous? Things like that. We might ask those things if they're big issues, but a lot of the other things that we ask are emotional questions. And how do you feel about this? What are your fears? And that's something that we're trying to educate other health providers on as well. But what are your fears and what can we do to make your experience better? Since we're not necessarily diagnosing and treating the source of an illness, we work together with the hospitalist or whoever's taking care of the patient in the hospital, because they're working on trying to address the cause, and we're working on trying to make the patient feel better despite the cause in case it doesn't go away. Or if it does, we still can help them feel better during that time. All palliative care doctors, well, not all palliative care doctors, because it is a new specialty, but new palliative care doctors are fellowship trained. And so they've undergone, a primary board certification in subspecialty, most of the time internal medicine or family medicine, but it's actually the largest co-sponsored fellowship in the list of all subspecialties. So you can go into it from almost any primary specialty: OBGYN, ER, surgery, psychiatry, physical medicine and rehabilitation. I'm going to forget a whole bunch of them, but I mean, it really is like a very widely sponsored. So they may come from a number of different backgrounds, but then they went through this palliative care fellowship, which is a year long, and is specialized training in symptom management and in having those difficult conversations. So the two big: advanced care planning and difficult conversations and symptom management, including complex symptoms, nausea from chemotherapy and things like that. So.
Thank you for the presentation. It's very informative. Some of us step into it unknowingly. I've had the opportunity, I guess, because it's been an educational process, to go through this with 5. And so it's very interesting. But what has been the hospital's outreach to the faith-based community? Ministers and pastors are the people that their congregation go to for expertise, guidance. And when you look at the timeline and you see how new it is, just what is Baylor's thoughts on bringing in the faith-based community? I know you all have a superb, very relevant chaplain services, but that is still not educating our communities, so that if we want people to have the information, I just think the faith-based is a place to reach out. Just a suggestion.
That's a great point. And we minister to, we serve people of all faiths. And you're right, that's one of the main community hubs and a place where people get their community support. And that's a great suggestion that palliative care kind of reach out to them and say, if you have anyone in your community that needs extra support and is going through something like this, maybe consider bringing this up with your doctor. As far as in the hospital, we have a chaplain service, and sometimes people say, oh, I don't want to talk to a hospital chaplain. The hospital chaplain can contact their pastor, they can contact their rabbi, they can contact whoever they need to contact from the community. It has become a little bit more difficult with COVID restrictions, but most of the time we can figure out a way to make sure that patient receives the support that they're comfortable with, because they may not be comfortable with a hospital chaplain, even though that chaplain would be more than willing and excited to offer them the support. The patient may not be their preference, and that's where the chaplains kind of help us facilitate getting the involvement of the church and of the spiritual leaders. So the question that we usually ask people is, do you have any kind of faith or spirituality that you rely upon? So we don't say, do you want a chaplain to come talk to you? Because that seems a little bit too aggressive. But just, do you rely on faith and spirituality, and is there anything we can do to support you there? Whether it be contact your church, contact someone else, or have a chaplain. Did that answer your question? Anybody else? Okay. I will just glance through these 2 slides because there are my references, so it proves that these were real studies. All the numbers and the letters are there, APA or anything or whatever.
Did
did not want to rush that because those were great questions. And Dr. Abbott, what great peace of mind that gives all of us. I mean, wonderful questions that we all have to face. I'll never forget my dad, as I was sitting in the cancer treatment with him, he leaned over to me and he said, I wouldn't be here if it wasn't for your mother. And I thought, oh, he didn't want to be there. So anyway, wonderful programming. Thank you. Just again, great peace of mind. Let's give another round of applause for Dr. Abbott. And let's also again thank Jonas Cole and Baylor Scott and White for all they do in our community. Thank you, Jonas. And as we come to the end of our program, we can all get back out and enjoy this beautiful day. I want to remind you of a couple of events coming up. We have the Join the Young Professionals group at Spooky Social on October 29th. I'm looking at Alex back there wondering what Spooky Social is. Sounds fun. We also get your networking in at the final Direct Connect of the year on November 18th. And last, please join us. This is my favorite, is Ringing in the Holidays at the 34th Annual Community Fellowship Breakfast on December 9th. So mark your calendars. So I hope you all have a wonderful day. Thank you for the program. Thank you for the sponsorship. Great to see all of you and have a great week. We're adjourned. Thank you.